cancer screening conversation. We're going to talk about breast and cervical cancer screening. We did lung and colon last week, which is going to be recorded. So if you missed that, we have the opportunity to be able to show you that down the road. And we're going to talk about where we are right now. My name is Alan Kaplan. I'm a family doctor and the primary care lead for the Central Region. And with us, we have specialists in obstetrics and oncology and breast imaging, who I'll introduce in just a moment. So in terms of what we're doing, we are going to record this as well. And as you know, with Zoom, we have both chat function and question and answer. If I could ask you to put comments in the chat, questions in the question and answer, so I can keep things organized. We're going to keep an eye on those chat boxes and make sure we get all your questions answered. If you're having any issues about connecting and so on, then please can contact Rukaya, the email address that's there, and she'll help you with that. And we're going to have all these slides available to you. I would like to just do a quick evaluation at the end, if you would, please, so you know what we did right, what we didn't do right, which hopefully will be nothing. And this is accredited, so you'll be getting your accreditation letter in the next few weeks. I'll start off with a land acknowledgement. In terms of where we are at South Lake Regional Health Center, we want to recognize and acknowledge the lands originally used and occupied by the first peoples of the Williams Treaty First Nations and other Indigenous people on behalf of our Central Region Cancer Program, and thank them for sharing their land. We have the Chippewas of Georgina Island as part of our region. We want to thank them as our closest First Nation community and recognize the unique relationship the Chippewas have with the lands and the waters in this territory. They are the water protectors and the environmental stewards of these lands, and we join them and thank them for these responsibilities. So this is a 2 hours credits between last week and this week. It's certified, so you'll get your certification for that. I'm Alan Kaplan. I'm a family doctor. Here's my financial conflicts. I do a lot of respiratory work and I do some pain work as well. So I have conflicts with most of the companies that do respiratory medications, vaccines, and so on. I'm involved in some government issues as well, but I don't think anything has to do with anything we're going to talk about today. There's been no financial support for this, other than the fact that I get paid as a primary care cancer lead. And in terms of mitigating bias, I mean, really my job is to improve primary care cancer screening in our region. So I think cancer is bad, and I think you'd all agree we'd like to do what we can to prevent that. So our objective is really to talk about the current guidelines for breast and cervical screening and manage appropriate follow-up and surveillance. We want to talk about special considerations and recommendations for screening. I'm going to touch on the impact of COVID-19 pandemic on our screening rates and how we've actually had some issues, but we're catching up. We can't talk about cancer without talking about the continuum. So, we're talking about what we can do in terms of not prevention, but in terms of screening. With screening becomes earlier diagnosis, and that all the way down the line improves treatment, improves recovery, and hopefully diminishes end-of-life care. So we're going to talk about screening here mostly today. Now, the reality is that we're actually doing a pretty good job, but overall, and this is a little bit outdated data, but you can see the overall net cases of new cancer are actually rising over time. So that seems a little bit scary. It's still the #1 cause of death in Ontario in terms of cancer by itself. But with that, because of our treatment strategies, we're actually having a decline in mortality in Ontario over time. So we're getting better at treating this dreaded condition, which is important as people have better outcomes, and we can improve that even further by better screening rates. And overall survivorship was up. So not only are we having outcomes because of earlier cancer detection and better treatments, but now we have a different population of people that have gone through the cancer journey and survived, which does have implications for us as treating clinicians in terms of people with the side effects of various treatments they've had. I see a lot of neuropathic pain, for instance, that causes that. So overall, our job as primary care practitioners is to make sure that we identify those people that require screening, to help them make decisions that are informed and make those decisions properly, to arrange and facilitate and conduct screening tests, and of course, arranging follow-up of abnormal tests. There's no point in having a test if we don't follow it up. And of course, it's been shown that a good relationship between the doctor and the patient can improve that screening rates. So currently we have 4 organized cancer screening programs. We talked about colon and lung last time. We're going to talk about breast and cervical screening today. So before I move on to that, just while I have this up here, could I have my co-speakers just take a moment to introduce yourselves?
Hi, I'm Felice Lackman. I'm a OBGYN at Markham Civil Hospital, and I'm your regional cervical screening and colposcopy lead.
Hi, I'm Samantha Feinberg. I'm a radiologist at Lakeridge, and I'm the clinical lead for the OBST.
Okay, excellent. Thank you. So we couldn't have anybody better placed to actually give us these talks today. So this is the kind of picture I'm going to show you across all the different cancers. And the bottom line is COVID resources got things reassigned to other things, and screening fell right down to pretty well off the map. However, as things opened up again, our rates have increased, and I'll show you the different numbers. So for colon cancer, you can see, pre-pandemic, the numbers we're at, the big fall, and then post-pandemic now, and it's even a little further along than this, we've actually reached better numbers than we had pre-pandemic. And in terms of colonoscopy wait time from having a positive FIT test, we want to get them within 8 weeks, and we're doing that better than we did pre-pandemic. So there's a lot of work going on behind the scenes to make this happen. Mammograms, same kind of picture, and Samantha, I'm sure you'll show some of the same kind of information, but the big fall off and then a recovery to better numbers than we had pre-pandemic. And again, importantly, our patients needing tissue biopsy with abnormal mammograms, that really didn't fall terribly. So those abnormal tests have really been dealt with by our surgical and diagnostic practitioners that have actually done a really good job to keep us up to date. Similarly with pap smears, recovery hasn't been quite as good. It's kind of hard to do a pap smear through the telephone, but Felice will tell you all about those new innovations. But again, in terms of colposcopy, a little fall off, but we're recovering very well. So same kind of picture for every single one. Now that's the cost of COVID. And the cost of COVID is that there's been a delay. It's just a reality. We know that a lot of people didn't get it. They're trying to catch up now, and we're trying to do that. This is a report that looked at what's happened in terms of that delay. So if you look at the top box there, it says colon cancer check. If you look at the total number of colon cancer cases, 127, which is, in terms of mortality means an extra 6 patients in terms of dying because they didn't get their cancer diagnosed early enough. With breast screening program, it's 10. The cervical cancer screening program, it's 6. So there is a cost. There's a cost to our having had all those people delay and not having their screening in terms of having more advanced cancers being picked up. And we're doing our best to catch up now, and we'll work away at that. So our plan today is really to review those best practices in cancer screening. We're going to give you some resources, some ideas of how you can do this and how you make it easier in your practice. And what I really want to do is get us all excited about this again, because it's been a long slug to get us to the point we are now. So we now have the opportunity to jump back in and get excited and do all the preventative care we have to, whether it's vaccinations, chronic care illness, but what we're really going to talk about today is cancer screening. So I'll stop sharing now, and Samantha, up to you to then do that. And we're going to talk about breast screening. And again, there's Q&A boxes there and there's chats, and I'll try to respond to the chats as we go through. You're muted, Samantha. Still muted. There you go. Excellent.
There we go. Okay, I know it hides the screen once you screen share. Okay, well, thank you for having me. I'm the clinical lead for the OBST. I'm really excited to be here for all the reasons Alan discussed. You got family, like primary care is really our partners in screening, and the people who really encourage our patients to come out for screening. So I'm really excited to be here to talk to you. Unfortunately, I have no conflicts of interest to declare. So this is our agenda for today. I wanted to just go over a bit of background of the breast cancer screening program, the eligibility criteria. Then I was going to talk a little bit about how the pandemic has impacted breast cancer screening performance for Central Region and also for the province. We can kind of compare. And then I also want to highlight recent OBSP initiatives, including breast density, screening trans and non-binary people in the screening program, updated referral criteria for the high-risk program, and the OBSP position on screening people ages 40 to 49. So it's just a bit of background. The OBSP is a provincial-wide organized breast cancer screening program that was launched in 1990. So it's one of the more mature screening programs in the province. It was designed to encourage Ontarians to get screened and lower their chances of dying breast cancer. So in the program since 1990, up until 2019, we've screened over 2 million women. We performed more than 9 million mammograms, and we've diagnosed almost 50,000 people with breast cancer through the screening program. So in terms of the program structure, the OBSP encompasses 2 tracks. There's the average risk track and the high risk track. And we also are involved in follow-up and assessment for people within the screening program. So in terms of average risk eligibility criteria, women, trans, and non-binary people ages 50 to 74 are eligible for the screening program through the OBSP if they have no breast cancer symptoms, have no personal history of breast cancer, do not currently have breast implants, have not had a mastectomy, and have not had a screening mammogram within the past 11 months. Okay, so in terms of the high risk eligibility criteria, so it's women, trans, non-binary people ages 30 to 69 are eligible through the high risk program if they've had genetic changes that increase their chance of getting breast cancer. They've not had genetic testing, but they've had genetic counseling because of a close family member with genetic changes that increases their chance of getting breast cancer. They have a greater than lifetime chance of getting breast cancer based on personal and family history, and or they've had radiation to the chest to treat another cancer before age 30 and at least 8 years ago. In terms of our screening guidelines, so average risk is people's ages 50 to 74, and they're screened with mammography, and most people are screened every 2 years. There's some exceptions. If they have higher than average risk, they may get called back every year, or due to breast density, they may get called back in 1 year versus 2 years. And in the high risk program, people, it starts at age 30, and they're screened every year with mammography and MRI. So, and if someone can't have MRI, then they'll be scheduled for a breast ultrasound as for supplemental screening. So those are our two tracks in the OBSP and the eligibility criteria for getting screened within the OBSP. Okay, so I wanted to talk a few minutes about the impact of the pandemic on breast cancer screening. I was asked by one of your colleagues, like why one of their patients, like why their patients can't get in for mammograms anymore. So I just thought I'd give a little more detail about the impact of COVID on the breast cancer screening program. So this is what happened between 2019 and 2022 in the breast cancer screening program. And I have Ontario and also the region. So let's see. So the gray line is 2019. So that's our baseline. And this is like our monthly volume. So as you can see in the province, we're screening like 50, 60,000 women a month in the province. And in this region, like almost 8,000 women a month as our baseline in 2019. In 2020, you can see there is the cessation of screening during the height of the pandemic. And then there's the resumption of services. You can see in 2021, that's the yellow line, like there was a huge effort to recover from the backlog. So like I know at my site, we were working like nights, weekends, a lot of extra shifts to try to recover from the backlog. It was really not sustainable from an HR level. Like it was hard while we were going through all these other HR issues from like different waves of COVID. So it was really hard to maintain the staffing level to maintain that level of service. And it was like hard to find, like it was hard, it was challenging, but the sites you could see across the province and even in this region, we're trying to kind of recover from the backlog. And then in 2022, you can see we're very close to the baseline in 2019. So I think that's really like our system capacity for, our current system capacity for screening mammography. So definitely like the wave one of the pandemic had challenges, but we have like systemic challenges that even were in existence before COVID. And we also had like different challenges during different waves of the pandemic. But as of now, we're pretty much very close to the baseline of 2019. So you can see with MRI, it followed a similar pattern. This is the high risk program, but the volumes are completely different. Like in the central region, we're looking at screening like 80 to 100 women a month. And this is for MRI, and the MRIs are prioritized. So we recovered faster and we're able to get to the baseline quicker than we are with the mammography volumes, because the scope is such a different, scope is much greater with the mammography volumes. So we've sort of reframed how we're looking at the backlog now. We're more looking at participants who are overdue for mammography. And all the sites, all the regions and all the regional cancer programs across the province now are able to access this data. So this is a tool that was developed during the pandemic to monitor volumes and participants. And I think the regions are really finding it useful to help resource plan, and they're coming up with a lot of like innovative programs to help get participants who are overdue in for screening. So here we're comparing like Ontario and Central Region in terms of percentage participants. And here you can see like overall in Ontario, there's about 250,000 women who are overdue, but a large percentage of them are in that first 6 months. So a lot of that might just is probably related to scheduling and just making your appointment. But now like the province and all the regions and even sites can like really target the volume of people who are overdue more than 6 months and come up with strategies and resource plan, different ways to get those people back in for screening. Okay, so I wanted to bring to this group, highlight some of the initiatives that are ongoing in the OBSP for this year. So the first one is improvement in breast density notification within the OBSP. So we're working on enhancing our breast density reporting and notification practices. It's called the Breast Density Notification Project, and it's to ensure participants can access their BI-RADS breast density classification, which is kind of the standard in the field for classifying participants with breast density classification, and also to develop education materials and communications for participants and their healthcare providers to enhance breast density notification and to help answer questions that patients might have. So you might have noticed, like for the past year or so, more in the screening reports, the radiologists have been reporting the percent mammographic density and the BI-RADS breast density. And I know as a radiologist, it's a little bit confusing. Really, it's the radiologist is doing the same thing. It's a visual estimation of the breast density, but the percent mammographic density on the OBSP reports is binary. So the radiologist just indicates if the participant is greater than or less than 75%. With the BI-RADS breast density, it's a quartile system. So there's 4 classifications, A, B, C, D. And this provides a more accurate assessment for the participants who aren't dense. Because the radiologists have been reporting both classifications, we were able to show there's a very high correlation between BI-RADS D and greater than 75% mammographic density. So we're able to now go forward with one breast density classification in the next few months. So you'll be seeing that on the OBSP reports, and that will change the recall recommendation of 1 year from the 75. When that is removed from the screening report, the 1 year recall recommendation for density will be switched to BI-RADS D. We've also undergone a jurisdictional scan to determine how best to implement direct breast density notification for participants. The normal results letters have been updated to indicate how participants can access their breast density information, and includes links to the new educational breast density webpage. And the screening report forms have been updated. They include BI-RADS breast density classification, but we will be moving to the one breast density classification. So just to illustrate, this is what the screening, one of the templates for the screening reports looks like. So right now, the radiologists are reporting the percent mammographic density and the BI-RADS breast density composition category. So we will be moving forward in the near future to just the BI-RADS breast density classification, which will hopefully be easier to understand. So in terms of upcoming work this summer, all the results letters will be in the near future include the breast density classification. There will be education materials for participants and providers to include information on breast density and help support conversations about breast density. The screening report will be updated to only have one type of breast density classification, the BI-RADS breast density classification. And there's currently a health technology assessment on assessing the appropriateness of supplemental screening for people with dense breast. So this is what the webpage looks like for providers, which if you click on that link on Ontario Health, it will provide you with breast density information. There's one for healthcare providers, and there's also one for patients. Okay, so I also wanted to update this group on the Ontario Health policy on screening trans and non-binary people in the OBSP. So as many people, I think in this audience, probably know that trans and non-binary people face many unique barriers and challenges when accessing cancer screening services. Some of it's systemic, related to data infrastructure limitations, but healthcare providers may not understand their needs. There's limited cancer screening guidelines for this population. There's a lack of clarity on eligibility criteria. And due to some of our systemic issues, they may not receive the full benefits of population-based screening. So all these issues result in barriers for this population to be less up to date with breast cancer and cervical screening than cisgendered women. So in 2018, there were policy recommendations developed to address these challenges and minimize barriers and improve screening experience for trans and non-binary individuals. And this is called the overarching policy for the screening of trans people in the Ontario Breast Screening Program and the Ontario Cervical Screening Program. There were 17 recommendations, and we're currently in the early phases of implementation of these recommendations. So this is an overview of the recommendations, mostly related to the OBSP. So eligible trans and non-binary people should be referred and screened through the OBSP and high-risk OBSP. And eligible trans and non-binary people with greater than 5 years of feminizing hormone use may be referred to and screened in the OBSP and high-risk OBSP. And the 1 year and annual recall criteria should also apply to all trans and non-binary people. Breast implants should not preclude otherwise eligible people from participating in the OBSP, and that's trans and also cisgendered women. And overall, we should reduce emotional and physical discomfort related to accessing screening services. So in terms of our our current phase 1 objectives, we're trying to develop and implement guidance for the sites on how to assess eligibility criteria on feminizing hormone therapy history. We're going to be sending correspondence letters to all OBSP participants, regardless of sex designation. And this is going to apply to the recall and the normal results letters. We will be including all people with breast implants who are otherwise eligible in the OBSP. And we're going to be supporting the sites to provide safe and inclusive screening services. Okay, so on to the next topic. I wanted to highlight high-risk OBSP referral criteria and how they're going to be updated for April 2023. So just a bit of background. So the high-risk program screens people ages 30 to 69 who meet the eligibility criteria and they get screened annually with mammography and breast MRI. And so there's 2 tracks of how they're referred in. Direct entry, like one category in the direct entry is people who've had a history of medicinal radiation. I'm referring to category B, which is people who are potentially at high risk, who are referred for genetic assessment to be determined if they're eligible for screening through the high risk program. In terms of the category B referral, so this is the category that's being updated. So this is I just did a snapshot of the current form. So if someone's had a first degree relative who's had BRCA1 or BRCA2 and not had genetic counseling, or they've had a personal or family history, like a breast cancer less than 35, a history of serous ovarian cancer, his family history of male breast cancer, they can be referred for a genetic assessment. However, in May 2021, the provincial hereditary cancer testing eligibility criteria were updated and released. So they have expanded the genetic testing panel to 19 genes associated with breast, ovarian, and prostate cancer risk. So this has resulted in more people now being eligible for genetic testing. So we're aligning our referral criteria to the new provincial cancer testing criteria. So here I'm trying to highlight how the referral criteria have changed. So previously, a personal history of breast cancer at less than 35, you could be referred for assessment to the high-risk program. That age has lifted to 45 years. So anyone who's had a personal history of less than 45 years can now be referred for genetic assessment. If someone has a limited family structure, that age is lifted to less than 50. And if someone's had a history of triple negative breast cancer, they can be referred for assessment up to 60. Okay, they've also expanded the definition of ovarian cancer. So previously it was history of serous ovarian cancer, and now it's a personal or family history of invasive ovarian cancer. Okay, and the criteria has also expanded from a personal or family history of breast and ovarian cancer to now also including pancreatic cancer or prostate cancer. So this new form will go live April 14th, 2023. I get asked a lot about screening people in their 40s. So I wanted to just explain a bit of background information and the OBSP positioning on screening the people in this age category. Okay, so the Canadian Task Force on Preventative Healthcare currently notes that screening people 40-49 should involve shared decision-making. They should involve consideration of the value of screening to the person. They do not recommend screening on a population basis. However, the discussion of shared decision-making and whether an individual, like the decision to be mainstream, could be made on an individual basis. So currently, people ages 40-49 are not currently screened as part of the OBSP. So our recommendations are aligned with the task force. We recommend that primary care providers should have a shared decision-making conversation with patients ages 40-49 who are interested in screening, and providers can refer patients for a mammogram outside the OBSP. As long as the person understands the risk and benefits of screening, this is an insured service. So all sites will accept people with a referral letter in ages 40-49 for screening. There are decision-making tools available to assist primary care providers to engage in shared decision-making. So some of the ones that we recommend is the decision-making tool from the Canadian Task Force. And I think the Ottawa Hospital Research Institute also has patient decision-making aids. So even though currently it's not necessarily recommended on a population level, there are a lot of, like, on an individual level, people have like different family histories and risk factors, so it may be appropriate more on an individual level. Okay, so today we talked about the impact of the pandemic on screening, some current changes to the screening program, such as changes in breast density notification, implementation of screening trans people within the screening program, and the OBSP position on screening people ages 40-49. Anyways, I want to thank you for having me. I really appreciate speaking to all our primary care providers, because we really couldn't, as a radiologist, we couldn't do what we do without you. And thank you for interpreting all our reports to all our patients. So thank you.
Samantha, thank you very much. If you just want a quick stop sharing for a second. There's a lot of questions about dealing with breast implants. There's some discrepancy between implants and transbinary patients versus regular patients,
Sure.
cisgender. Do you want to just quick talk about the indications for breast implants and how you do that?
So people with breast implants, like when the program started, they weren't included in the screening program. However, all the recommendations for screening people average risk would apply to anyone with implants. So we will be implementing the recommendation of screening people with breast implants in the OBST. It will be this year, but it's not live yet. So there will be communication to primary care when that change happens. But our recommendation is that anyone who meets the criteria for average risk screening, whether they have implants, if they have implants, they should still be screened with mammography.
There's a question about why to age 69 for high risk, not to 74 like everyone else.
It has to do with the risk of breast cancer reaching the population level risk.
And what percent, like when they have genetic counseling and they get a risk assessment for lifetime risk of breast cancer, do you have any idea of how high that risk number is before they'll get approved for the high risk group?
When their risk assessment, yeah, when they go for the assessment, when it's a 25% lifetime risk, they will get into the high risk program.
Right. So Dr. Roman, I put in a comment, she has a patient at 24% lifetime risk, so she's a little frustrated and wonders whether she should still be doing mammograms and MRIs outside the program, or what should she do?
Well, a recommendation, if you don't need it, you might not. Okay, so they are always what I tell people, they are always updating the risk assessment models. And so before they weren't including breast density, but now they are including breast density. And part of that change was that now it's because they use the BI-RADS breast density for the risk assessment. So sometimes, like if it's been a period of time, sometimes if the criteria has changed, you can maybe get reassessed.
So prostate cancer as a new risk for high risk, is that dependent on age at all, of the age of the onset of prostate cancer? Does that make any difference? Hard question.
I can't answer that question, but I think it's a family history of prostate cancer. So I don't think there's an age cutoff, but you'd have to talk to your local genetic specialist.
Well, there's obviously a difference between people getting prostate cancer young and strong family histories. There's obviously a genetic component. For someone who gets prostate cancer in their late 80s or 90s, that's almost like expected, and it probably isn't the same thing. So I think we're talking about genetic risk to answer the question. I don't have the exact number there. So right now, prostate cancer.
Yeah, I could ask and get the answer back. But. And
Dr. Stern's wondering about the Americans. Are they still doing 40? And why the difference? Is it just the U.S. doing everything to everybody, or is there any reason for that?
Well, there's different organizations that we align our recommendations with the Canadian Task Force. So, okay. To make it simple.
There is a group of radiologists right now who are making a lot of noise about everyone should be doing it at the age of 40, but the evidence right now that we have is to start it at 50. So that's where we are. This may change.
Well, we recommend starting age 50 on a population level, but on an individual level, like everyone has their own family history, it might be appropriate to start at 40. But that's more of an individual decision.
And the report should give a BI-RADS number, right? A firm number. It shouldn't be a range, right? So some people are getting reports with ranges on it, which is probably just a typo, I would imagine.
Well, there's been many updates to BI-RADS since I think it initially came out in 2003, and it got updated in 2013. So the original from 2000, the first version of it had a percentage range, like where it went 0 to 25, 25 to 50, 50 to 70, and greater than 75, which was sort of aligned with the terminology in the OBSP report of greater than 75%. So they might be using the older terminology. I would maybe feed that back to the cancer screening manager, because we have a template with the updated terminology. That being said, the ACR has looked at the way radiologists classify using the 4 categories. And no matter what version, it's very consistent with the population level, who's being categorized as A and who's being categorized as D.
So the doctors, if you're getting the BI-RADS, it's not clear to you, then please reach out to CCO or reach out to me and see if we can clarify it for you.
Yeah, because we have a template out where they're supposed to use the letter and the descriptor to make it clearer.
And I guess the only other frustration people have, which you touched on, is sometimes getting the results of pap smears is taking a long time, and there seems to be some difference that HPV testing are coming back sooner, and that's frustrating as well if they pay for it. I know in BC there's a really big problem right now with the timing to get back pap smears. We're much better in Ontario. So, well, maybe better in BC, not for pap smear results, but any comment on this at all?
Well, the pap smear is not my area, so.
It's probably a good question for me to answer, Alan, after my talk.
Absolutely right. I'm just trying to get to all the questions in my chat. I'm so sorry. Okay. Well, with that, actually,
Okay.
that's a really good segue for Felice then. So why don't we just quit there? And Samantha, thank you so much for.
Okay. Thank you for
doing this.
having me.
And
Okay.
Felice, why don't you jump in? Take care, and jump in and get started, please. I'll just share screen.
Okay, let me just share my screen. So good evening, everybody, and thank you for coming to hear this talk. I hope that I'll be able to finish. We're starting my segment a bit late, but we'll get through it all, and I'll be able to answer all of your questions at the end, hopefully. So we're going to talk about this cervical screening program. I'm going to give you an overview, and we're going to talk about HPV testing implementation. Always a hot topic. It's been a hot topic for I don't know how many years now. I don't have any disclosures to share. So while you read this little comic that I put on for you, I'm going to tell you that HPV testing is hopefully set to be implemented in the 2024 to 2025 range. That's our current estimate, but don't hold me to it because it has been changing monthly. Okay. So today we're going to do an overview of the Ontario Cervical Screening Program. I'm going to talk about the recent changes to the OCSP, and that's really what I want to focus on. A lot of these changes have been sort of a soft launch during the pandemic, and there's a lot of confusion out there about how often to do PAPs and what needs to be referred to colposcopy. So we're going to spend the most chunk of time on that. We'll talk about implementing HPV testing in Ontario, and I have a few resources to give you at the end. So let's just start with the overview of the screening program. Cervical cancer, although not that common, still presents quite a burden to our society. So in 2022, 583 people in Ontario were diagnosed with cervical cancer, and about 155 of those will die from it. So the death rate of cervical cancer is actually quite high. Without cervical screening, these numbers would be much higher. Cervical cancers are found in people who mostly have never been screened or are being screened less often than current cervical screening guidelines. We know that cervical screening significantly reduces the incidence of cervical cancer, so reduces new cancer cases, reduces morbidity, which includes loss of fertility in patients who are young and being treated for this cancer, and certainly decreases cervical cancer-related mortality. The OCSP is a population-based organized screening program, similar to breast, similar to colon, similar to lung. And the goal of this program is to reduce people's risks of developing or dying from cervical cancer by increasing the percentage of eligible people who get screened regularly and the percentage of people who have a timely and appropriate follow-up when necessary. So a few slides on numbers. So what this slide shows us is the percentage of screen eligible women who were screened starting 2020 to 2021. So you can see we were at about 53% of screen eligible women were being screened prior to and just to the beginning of the pandemic. And this line actually has slowly decreased over time. And now we're at 52% of screen eligible women. And if I go to the next slide, even though we're actually doing more PAP tests, so you look at the purple line, and this is 2022, and you can see the numbers are higher than 2019, and it looks like we're doing great at getting PAPs done. We're actually screening less of the population that is eligible than we were before. And that's because there are more eligible people to screen. So we're only screening about half the people who should be screened. And there are lots of barriers to being screened and to doing screening. And I've talked about those in other talks. We're not going to really delve into that. But even though if we look at this slide, it looks like we're doing better, we're actually not doing better. This slide shows the high-grade Pap test to colposcopy wait time. A lot of this information is now skewed because, as Dr. Kaplan talked about, we've had a huge problem with the delay in getting Pap results in our region and in the province. And so instead of looking at specimen collection date to colposcopy date, we've broken it up into specimen collection date to result, which you can see over time has gone up. So we're getting delays in getting our results. And then result report date to colposcopy, which is actually getting better. And then this slide just shows the individuals with a high-grade Pap test with no follow-up in our region. And these numbers are also a little bit skewed because we've had this delay in high-grade Paps, because we've had the delay in getting the reports and getting people with high-grade Paps into colposcopy. So that's been a huge problem in our region over the last few months. It's gone up to about a 6-month delay. It seems to be improving now slowly. The Ministry of Health is aware of this. Cancer Care Ontario is aware of it. Ontario Health is aware of it. It is a bit lab dependent. It depends on which lab you use, but it's been a huge, huge problem. So let's go on to talk about the recent changes to the cervical screening program's recommendations for cervical screening. So this screening pathway was updated in 2022, although that was the official screening pathway update. Some of the changes to the cervical screening program were launched during the pandemic in a very soft way. And so there has been a lot of confusion about what we're supposed to be doing with Pap smears. So here they are. People with a first-time low-grade Pap, so LSIL, or an atypical squamous cell of undetermined significance, so LSIL and ascus, should be rescreened with another Pap with cytology in 12 months. And this also applies to people who have an LSIL or ascus. If they have their repeat in 12 months and it's normal, they also need another one in a year. So it used to be that there was a guideline that said a first-time LSIL or ascus could be referred to colposcopy. These referrals should now be declined because there's very little evidence to support colposcopy after one low-grade Pap. And when this was launched, updates were made to the lab recommendations on the Pap smear results. So the lab should be saying recommend repeat in 12 months, or if the recommendation is different, those updates should have been made. So here it is in a graphic way. So this is the screening pathway. Anyone with a cervix, so that includes women, trans, non-binary, anyone who has a cervix is eligible for screening. The recommended age of screening has increased to starting at 25 and not 21, and I'm going to talk about that in the next few slides. And these are obviously asymptomatic people. So we're not screening symptomatic people with abnormal bleeding or cervical lesions. These are people who have no symptoms. So our first line of screening is the cytology or Pap test. So if we go to this area of the slide, if that Pap is normal, return to cytology in 3 years. So screening every 3 years. If it's ascus or it's LSIL, we now repeat in 12 months. And then we go down these pathways. If you repeat in 12 months and it's normal, they get another repeat in 12 months. And if that's normal, they go back to every 3 years. If you repeat in 12 months and it's still abnormal, either ascus or worse, then they should be referred to colposcopy. Or if they've had a normal and then they have another abnormal, they should be referred to colposcopy. And the same pathway exists for the LSIL Pap. Nothing has changed for the high-grade Paps, which include ASK-H, HSIL, atypical glandular cells, and adenocarcinoma in situ. Those automatically are referred to colposcopy right away. So let's talk a little bit about HPV testing now in Ontario, not what it will be. So right now, HPV testing is not an insured test in Ontario, which means it is not equitably available to all the people in Ontario. However, it is available on a patient pay basis, and it is available in some hospital colposcopy clinics, not all of them. So HPV testing is not the standard of care with a first-time ASCUS or LSIL PAP, and it's actually contraindicated in a high-grade PAP. However, we know that this test can be offered to people, and if they make an informed decision to have an HPV test after their low-grade cytology, these are the recommendations as to how that should be dealt with. Now, we know it's inequitable and we know it's not fair, but it is still available. And there are some people who will have the test. So it's important that we have guidelines to follow in the people who have the test as to what should happen to them once those results are available. So if they have an HPV test after a low-grade PAP, and their HPV test shows HPV 16 or 18 positive, and the lab should be reporting this. So some labs report 16, 18, and 45, but most of them will report as 16 and 18. If there's 16 and 18 positive, their risk has increased and they should be referred directly to colposcopy. If they're non-16, 18 positive, it's actually safe to repeat their cytology in a year. That's a moderate risk category. And if they're HPV negative, they can return to routine screening with cytology every 3 years. And this is the group that mostly benefits from the HPV test, because a lot of these people will be able to avoid colposcopy, even if they have 2 abnormal low-grade PAPs in a row. Here are some of the reasons for screening starting still at age 21. So we are encouraging people to start cervical screening at age 25. And this is based on moderate quality evidence suggesting that people under 25 do not benefit from cervical screening. And the reason for that is they're at quite a low risk of having cervical cancer. However, people who are immune compromised, who are sexually active or have ever been sexually active, should be initiating screening at age 21. So that includes people living with HIV or AIDS, regardless of their viral load, any transplant recipients, people who are requiring treatment with medications that are immunosuppressive, people with systemic lupus, regardless of whether they're on treatment, people with congenital immunodeficiency, and people with renal failure and requiring dialysis. So it's not a huge part of our population, but it's important to remember those categories because they should be screened earlier. Here's the rationale for encouraging initiation at age 25. Just an FYI, when HPV testing is our primary screening test, we won't be encouraging people to start at age 25. It will start at age 25, and these tests probably won't be accepted in people younger than 25. So cervical cancer is extremely rare in people under 25. From 2014 to 2018, only 29 new cases of cervical cancer were diagnosed in people under 25, compared to 2,900 cases for all ages. The incidence of cervical cancer in people under 25 was 0.3 per 100,000 compared to 8.1 per 100,000. So what happens when we screen people younger than 25 is it results in a lot more screening, a lot more colposcopy, and tests and treatments that likely will not be beneficial to them. So HPV testing. So HPV, or human papillomavirus, is an extremely common infection. Over 80% of people will have at least one HPV infection in their lifetime. So that's everybody. HPV is out there. I like to tell my patients it's like pollution. If you breathe in pollution. If you're a normal sexually active person, you're going to be exposed to HPV. The good news is most of these infections are transient and they resolve on their own over several years. So typically it takes 12 to 24 months for the infections to resolve. Of course, some of the infections can persist and lead to cervical cancer. And we know those are the infections with high-risk HPV, most commonly number 16 and 18. So the risk of cervical precancer is related to the duration of the HPV infection subtype. If the infection persists for longer, which means the immune system can't clear it, they're more likely to get precancerous changes. If they have a robust immune system and can clear their infection, they're much lower risk of getting precancer or cancer. So when HPV is implemented as our primary screening test, It will be implemented in both the screening population and in screening-related colposcopy. In the screening population, it will be the primary test, and if the HPV test is positive for high-risk type, then a reflex cytology will be performed. So a reflex Pap test, and that will inform us as to whether or not the patient needs to be referred for colposcopy. And in the colposcopy population, HPV testing will be used as a co-test with PAPs in order to help us determine who is eligible for discharge and their screening frequency once they're discharged from colposcopy. This slide compares HPV testing and cytology and the sensitivity of HPV testing. So its effectiveness in detecting a precancer in people who have that cancer is much higher than a PAP, 96% versus 53%. The specificity of a PAP is a little bit higher because it's actually detecting the type of abnormal cell in the cervix. What does HPV detect? It detects oncogenic types of HPV, whereas a PAP just detects abnormal cell changes in the cervix. HPV testing is objective and reproducible. Cytology is subjective. So the impact of HPV testing will be that we can better screen for precancer and cervical cancer. It will eliminate unnecessary colposcopy referrals. It's safe, earlier, and more appropriate discharge from colposcopy will enable us to get people out of colposcopy much earlier. So in all, it will improve cervical screening and colposcopy in our province. This slide just shows why it's so difficult to implement a new test. We need changes to legislation, regulations, including the schedule of benefits for physicians and the lab. We need to procure and onboard an HPV test system, and it has to be tested to make sure it's appropriate. We need to update technical infrastructure systems, processes. We need to update operational infrastructure, and we need to implement change for all the stakeholders. And so this is part of the reason why it's taking so long. Of course, the pandemic really threw us for a loop, and implementing of HPV was sort of put on the back burner, but it's revving up again. And these things are all happening in the background. It just takes an incredible amount of time. So this resource, I know it's hard to see, but we'll definitely share all the slides, and the link will be there. This is the cervical screening program pathway, and it has all of it there, everything that I went over. So it's useful to keep that handy. And that is the end of my talk.
Okay, excellent, Felice. So why don't you stop sharing now? We do have some questions, and Rakai has put that link in the chat box, everybody. So I'll go back to Andrew's first question about the delay. I think you've answered that at this point nicely. It is infrastructure and time, and not much we can do about it. So is there any way to fast track these results?
No. I'm looking for the stop sharing button, and I can't seem to find it.
It should be usually on the top right, on top of the right side. You may have to hover your mouse against the top. Yeah, there you go.
Okay. So yeah, the fast tracking of results.
You just have to hang in.
The delay in getting PAP tests back has been abominable, and it's terrible. I saw the question about, if you order an HPV test, you seem to get the PAP test back sooner. I imagine because the labs have a fast track for processing HPV testing, and they just haven't been able to deal with backlog of PAP tests. There's no magic. There's no way of getting the PAPs back earlier, but it seems to be on its way back to hopefully normal. It's a slow process.
And I'm sure the HPV funding is different, and that facilitates that. So that's probably why you get it back faster with an HPV test. A really good question is, when will the preventive care bonuses target for PAPs align with the guidelines? Because they're really not the same right now. The answer is it's up to OHIP probably, right?
Yeah, the scheduled benefits will be adjusted once HPV testing comes into play.
And I guess maybe the definition of what sexually active is. I know your thoughts on this, but maybe you can share that because people are wondering when they can start. If people stop being active, can they stop doing pap smears? So I know this is one of your.
So the definition for cervical screening is any sexual contact. So HPV is not a fluid-borne virus like HIV and hepatitis. It's a skin contact virus. So any kind of contact, it doesn't have to be penetration. Genital to genital contact is the most efficient way of getting this virus, but it could be hand to genital, it could be oral to genital, and it doesn't have to involve penetration. So that's the definition of sexual contact for cervical screening. And anyone who has ever been sexually active in that context should continue to be screened until age 70. So HPV infections can be dormant and they can sit there for a long time. So even if someone stops being sexually active, they could still have HPV sitting there, which can then activate later. So these people need to be continuously screened until they reach the age of 70.
Do you have any technical hints on doing a pap smear for people who are quite large? It's hard to see the cervix.
So obviously different size speculums come in handy and not everybody has access to those. In people whose pap smears are difficult, those may be appropriate referrals to a gynecologist if they really can't see the cervix with the equipment they have. But positioning on the table is important, and an appropriately sized speculum.
And sometimes when the cervix is pointing down, putting the fists underneath and lifting up can actually be a little hint to get fine.
Yeah, pelvic tilt can work too.
So some questions also about the change in the ASCUS recommendations. How come they've been made?
To 12 months instead of 6 months?
Yeah.
So with the chances of developing a cervical cancer with a low-grade PAP is very low. And most of these low-grade PAPs and the HPV that's causing them will resolve in the 12 to 24 months. So it's very unlikely in a 6-month period that you're going to see a rapid progression to a high grade or a cancer. And most of the time, those changes will resolve. And so that's the rationale for delaying till 12 months.
Now, a couple of things about HPV. What if someone has a normal PAP that is positive for HPV? Do we change our frequency of the test?
So that's a great question. When we initiate HPV as our screening test, there will be a whole bunch of patients who are HPV positive with normal PAPs that will end up in colposcopy because of their positive HPV. But what that shows is that even though they have an HPV infection, their immune system is keeping that at bay and it's not causing cervical changes. And so the current recommendations in someone who has a positive HPV test who has been through colposcopy and has a normal cervix and only a low grade or a normal PAP is that they go to annual screening. So their risk is mildly elevated, but not elevated enough to have colposcopy. So those patients will be in a yearly screening program as opposed to every 3 years.
I guess it also depends on which serology they're positive for, which level of HPV.
Yeah, 16 and 18 is different than the other high-risk groups, types.
An interesting question, is HPV testing deemed to be cost effective?
It will be when it's our primary screening test.
And Shalini asked about Gardasil, and does that change our screening practice because hopefully it'll decrease incidence of cervical cancer?
So that's a really good point. The screening population that is aging, a bigger proportion of those people have had the vaccine. So every year, more of them have had the vaccine. So that's another reason why we will likely see fewer precancers and cancers of the cervix. So it's not going to change our screening recommendations because the HPV screening recommendations are taking that into account. Those screening recommendations aren't published yet because we don't have the test available yet, but that is taken into account in that most our percentage of the population that's been vaccinated is growing.
Now, the HPV actual testing, you just described how you actually do that test. And the other question is where are the forms? Well, right now, this is a private test only. So once we actually bring it into the public, then all those forms are going to be established for everybody and they'll get them. But what about the private testing? How do you do that?
So an HPV test is not exactly the same as a pap test right now. It's the same room, it's the same specimen jar. And most of the labs on their cytology form have an area at the bottom that says HPV testing. So it's done on the pap specimen. It's exactly the same test.
And question about doing pap smears on people that have never been sexually active.
So if they've never, we've touched on this, if they've never had sexual contact, whether that's touching or penetration, then they don't need a pap. But if they've had any type of contact, they need a pap test.
And it seems like some clinics are being approached by labs sort of pushing their super fast pap smears and HPV testing as something for patients to pay for. So the question from the physician was, obviously this is not legal, but if it was, who would they report this to? But I guess a private company is a private company. What do you think?
I haven't heard about that, but obviously this isn't something that in our healthcare system, we would pander to.
You're not really supposed to do private stuff, but again, people will do that. And what about people who have been on a biologic and test negative for HPV? So what do we do then? They're high risk because they're immunocompromised, but they're negative for HPV. So how do you follow up for that?
I mean, the only difference between the immunocompromised population and the immunocompetent population is age of initiation right now, 21 versus 25, but they follow the same guidelines.
And that will include in the future when we get to this, doing the HPV repeatedly, right?
Yeah.
I think we've got to most of the questions there. I think I've got them all there. There was one in the chat that I just started looking at. Hi Debbie, you talked about HPV testing with if abnormal pap smears on a regular basis, patients are happy to pay for it, and it's helped with her referrals for colposcopy. So that's more of a comment that if you use HPV testing in your practice in that way, it's going to make a big difference to how many people end up needing colposcopy because you've established whether or not they're high risk. So
correct.
Thanks, Deborah, for that. Okay. Hope I've got all the questions there. I think we're probably at about time, and I want to respect everyone's dinner time and evening. And thanks, Dr. Lackland, for a wonderful talk as always, and always stimulating to make you think. And the future is coming for HPV, guys. Don't worry that you don't have all the answers yet. We're working very hard to make sure that all the questions and answers, including different requisitions and stuff, are all been worked out. I've actually been reviewing those already. So it's coming, and we will educate you well about this before it gets rolled out. We still have probably another year before it's going to happen. So don't stress about it. But if you want to do as Deborah has done and start implementing it now, there's a cost for it. It's private labs, and most of the private labs are wanting to do this. So you can start implementing your practice now if patients are willing to pay for it. So any last comments, Dr. Lackland, for you?
No, I'm good. Thank you. And thank you all for coming and listening to the talk.
Thanks everyone for coming. If you have any other questions, so reach out to Rakai and send them on. We'll try to get them answered for you. I want to thank my panelists for doing such a great job of educating all of us. And I want to thank all of you for joining. And I also want to, the lady behind the scenes is Rakaya, and she does a great job of getting this organized. So always make sure to thank her. So I'll say to you all, stay safe, have fun, screen, and I look forward to having a conversation with you in the future. So have a great night.